Cyclophosphamide is a widely used cytotoxic and immunosuppressive agent, and its drug interactions can impact efficacy and safety. Here are key interactions to consider. 1. CYP450 enzyme involvement. Cyclophosphamide is metabolized primarily by CYP2B6 and CYP3A4 enzymes in the liver to its active metabolites. Interactions affecting these enzymes can alter its therapeutic and toxic effects. A. CYP inducers. Efficacy. Drugs that induce CYP enzymes can reduce cyclophosphamide's effectiveness by enhancing its metabolism into inactive compounds. Examples: rifampin, phenytoin, carbamazepine. B. CYP inhibitors, toxicity. Drugs that inhibit CYP enzymes can increase cyclophosphamide levels, raising the risk of toxicity. Examples: fluconazole, ketoconazole, amiodarone. Other cytotoxic agents. Combining cyclophosphamide with other chemotherapy drugs can enhance its therapeutic effects, but also increase the risk of myelosuppression and secondary malignancies. Example: doxorubicin may increase cardiac toxicity risk. 3. Immunosuppressants. Concurrent use with other immunosuppressive agents, e.g. tacrolimus or mycophenolate mofetil, can increase the risk of infections or exacerbate immunosuppression. 4. Anticoagulants. Cyclophosphamide can increase the risk of bleeding by altering warfarin metabolism. Close INR monitoring is required. 5. Nephrotoxic agents. Cisplatin or aminoglycosides can exacerbate cyclophosphamide-induced nephrotoxicity and hemorrhagic cystitis. 6. Live vaccines. Cyclophosphamide suppresses the immune system, so live vaccines, e.g. MMR, varicella, should be avoided due to the risk of uncontrolled infection. ARC7. Cardiotoxic agents. Drugs like anthracyclines or trastuzumab can increase the risk of cardiotoxicity when used with cyclophosphamide. 8. Other specific drugs. Allopurinol may increase the risk of bone marrow suppression. Ondansetron, no direct interaction, but combined use in chemotherapy regimens requires careful monitoring. Cimetidine can inhibit cyclophosphamide metabolism, increasing toxicity. Monitoring recommendations. Hematologic, regular CBC for bone marrow suppression. Renal and hepatic, monitor for signs of nephrotoxicity or liver dysfunction. Cardiac, assess for arrhythmias or cardiotoxicity in high-risk patients. If you need more detailed pharmacokinetics or specific interaction management strategies, let me know. In rheumatology, cyclophosphamide is often used as an immunosuppressive agent for severe autoimmune diseases such as systemic lupus erythematosus, SLE, vasculitis, and systemic sclerosis. Drug interactions in this context are critical to optimize outcomes and minimize risks. 1. Immunosuppressive agents. A. Methotrexate. Both drugs suppress the immune system, increasing the risk of infections and pancytopenia. Consider using folic acid to reduce methotrexate toxicity. Avoid co-administration unless benefits outweigh risks. B. Azathioprine. Increased risk of myelosuppression when combined with cyclophosphamide. Monitor complete blood count, CBC, regularly. C. Rituximab. Sequential use may increase immunosuppression and infection risk, e.g. progressive multifocal leukoencephalopathy, PML. Combine only in refractory diseases and ensure prophylaxis for opportunistic infections, e.g. PCP, fungal infections. 2. Corticosteroids, e.g. prednisone, frequently used in combination with cyclophosphamide for severe autoimmune diseases. Increased risk of infections and osteoporosis. Ensure prophylaxis with bisphosphonates for osteoporosis. Trimethoprim sulfamethoxazole, TMP-SMX, for pneumocystis jirovecii pneumonia, PCP. 3. Biologic agents. A. TNF-alpha inhibitors, e.g. infliximab, etanercept. Combining cyclophosphamide with TNF inhibitors increases the risk of infections. Avoid concurrent use unless absolutely necessary. B. IL-6 inhibitors, e.g. tocilizumab, increased risk of neutropenia and infections. Close monitoring of white blood cell WBC count is recommended. C. Abatacept. Combination may result in additive immunosuppression and increased infection risk. 4. Antimalarials, e.g. hydroxychloroquine. No direct interaction, but co-administration can reduce the risk of lupus flares. Cyclophosphamide-induced immunosuppression may enhance hydroxychloroquine's role in controlling systemic inflammation. SIDS. Cyclophosphamide can potentiate nephrotoxicity when combined with NSAIDs like ibuprofen or diclofenac. Avoid or use cautiously in patients with impaired renal function. 6. Drugs for uric acid control. A. Allopurinol can increase the risk of bone marrow suppression. Monitor CBC if combined, particularly in vasculitis or lupus nephritis with hyperuricemia. B. Febuxostat, safer alternative but should still be used cautiously. 7. Antibiotics. A. TMP-SMX, commonly used for PCP prophylaxis but can cause additive bone marrow suppression. Monitor CBC closely. B. Fluoroquinolones may increase the risk of neutropenia and infection when combined with cyclophosphamide. 8. Vaccines. Avoid live vaccines, e.g. zoster, MMR, due to immunosuppression. Inactivated vaccines, e.g. influenza, pneumococcal, are recommended before starting therapy. 9. Antifibrotic agents, e.g. nintedanib, used in systemic sclerosis with interstitial lung disease. Combining with cyclophosphamide increases the risk of hepatotoxicity. Monitor liver function tests, LFTs, closely. Monitoring in rheumatology, CBC with differential. Monitor for leukopenia, anemia, and thrombocytopenia. Renal function, avoid concurrent nephrotoxic drugs. Liver enzymes, if combined with hepatotoxic agents. Infection prophylaxis, start TMP-SMX, antifungal agents, or antivirals as needed. For specific protocols, e.g. lupus nephritis or ANCA-associated vasculitis, additional adjustments may apply. Let me know if you need disease-specific details. Cyclophosphamide, C, is a cornerstone drug in managing proliferative lupus nephritis, class 3-4. It is highly effective but comes with significant risks of drug interactions that can affect efficacy and safety. Here are detailed interactions relevant to lupus nephritis management. PA1. Immunosuppressive drugs. A. Mycophenolate mofetil, MF. Typically used as an alternative to CYC during induction or maintenance therapy. Interaction. Both drugs cause myelosuppression. Concurrent use can lead to severe pancytopenia and infections. Management. Avoid simultaneous use. Switch therapies if CYC is ineffective or contraindicated. B. Glucocorticoids, e.g. prednisone, frequently combined with CYC for induction therapy. Interaction. Potentiates immunosuppression, increasing the risk of infections, e.g. bacterial, fungal, or viral. Management. Prophylaxis with TMP-SMX for pneumocystis jirovecii pneumoniae is essential. C. Biologic agents, rituximab, belimumab, used in refractory cases. Interaction. Additive immunosuppression when combined with CYC, significantly raising infection risks. Management. Sequential rather than concurrent use is preferred. Monitor for opportunistic infections, e.g. PML. 2. Antibiotics and antimicrobial prophylaxis. A. TMP-SMX prophylaxis for PCP. Interaction. Both TMP-SMX and CYC can cause myelosuppression and exacerbate neutropenia. Monitor CBC regularly. Consider alternatives, e.g. dapsone if cytopenia occurs. B. Fluoroquinolones, e.g. ciprofloxacin. Interaction. Increased risk of bone marrow suppression when combined with CYC. Management. Use cautiously. Monitor hematologic parameters. C. Antifungals, fluconazole. Interaction. Fluconazole inhibits CY2B6 and CY3A4, reducing CYC metabolism and increasing toxicity. Management. Reduce CYC dose or use alternative antifungals if necessary. 3. Vaccines. Live vaccines, e.g. MMR, varicella, zoster, contraindicated due to immunosuppression, risking disseminated infection. Inactivated vaccines, e.g. influenza, pneumococcal, safe and recommended before initiating CYC therapy. 4. Nephrotoxic agents, e.g. ibuprofen, diclofenac, interaction. Concurrent use with CYC may worsen nephrotoxicity, especially in lupus nephritis patients with renal impairment. Management. Avoid routine NSAID use or closely monitor renal function. B. Aminoglycosides, e.g. interaction. Synergistic nephrotoxicity with CYC, especially in patients with reduced renal function. Management. Avoid combination. Consider safer alternatives. 5. Warfarin action. Cyclophosphamide can alter warfarin metabolism, leading to unpredictable INR levels and increased bleeding risk. Management. Frequent INR monitoring is required when these drugs are co-administered. 6. Uric acid lowering drugs. A. Allopurinol. Interaction. Increases the risk of bone marrow suppression by interfering with purine metabolism. Management. Use cautiously. Monitor CBC. B. Febuxostat. Interaction. Safer than allopurinol, but still requires close monitoring for hematologic toxicity. 7. CYP450 enzyme interactions. Cyclophosphamide is metabolized by CYP2B6 and CYP3A4 into its active form. Drugs affecting these enzymes can alter its therapeutic and toxic effects. A. CYP inducers, CYC efficacy. Examples: rifampin, phenytoin, carbamazepine. Effect: increased CYC metabolism reduces active metabolite levels. Management: avoid in lupus nephritis patients on CYC. B. CYP inhibitors. CYC toxicity. Examples: fluconazole, amiodarone, erythromycin. Reduced CYC metabolism increases toxicity, e.g. myelosuppression, hemorrhagic cystitis. Management: dose reduction of CYC may be necessary. 8. Fertility-sparing agents. Gonadotropin-releasing hormone, GnRH agonists, e.g. Leuprolide, used to preserve ovarian function during CYC therapy. Interaction. No direct interaction, but GnRH agonists may worsen menopausal symptoms in female patients. 9. Supportive therapies. Mesna, administered to prevent hemorrhagic cystitis, a well-known adverse effect of CYC. Interaction. No significant drug interactions, but essential to reduce urotoxicity. 10. Monitoring and management. Regular monitoring, CBC, for myelosuppression. Renal function, serum creatinine, eGFR. Liver function, ALT, AST if on hepatotoxic agents. Infection prophylaxis. Ensure TMP SMX or antifungal prophylaxis. Adjunctive care. Maintain hydration to minimize cystitis risk. By understanding these interactions, you can tailor cyclophosphamide use to ensure maximum efficacy while minimizing adverse effects during lupus nephritis management. Let me know if you need further details.